When we're taking medications, we're generally tweaking or tricking or modifying our endogenous biochemical pathways. Usually that change is pretty harsh for the system. You do this with cannabinoids, and it's such a close mimicking of what our system does anyway that we don't see those side effects.
You've got such a fantastic book with evidence-based, health benefits of cannabis and CBD. Why do you think the DEA has been so slow to align with modern science?
I think it's politics. I think DA generally has been notoriously known for moving exceedingly slow. They have been refusing to evaluate some evidence on the pretense that it's not good enough, that the studies are not good enough, or they would say something along the lines, well, if the study is done in Europe or Israel, we're not going to consider it. There are certain things that they have done that's simply done just the way they do business and has nothing to do with evidence. It's simply the way they process things. There's also a lot of regulatory problems. So that's probably one of the bigger challenges for them. Generally speaking, it would be a completely unique precedent for DEA to take a regulatory step on a non-medication substance. They never they never laxed anything. They've only, in fact, you've all probably heard back in the summer, there was this whole thing about FDA was supposed to approve MDMA to reschedule it and put in, and they refused. And they took a weird process, and that should have been easy because MDMA is a drug. It's a synthetically made substance. The consistency is predictable. There is no botanical variations expected, so you can, and even that they still had a problem. So it's a lot of regulatory hoopla. Unfortunately, I think a lot of this has to do more with most of these older agencies are run by people who are, old school. Let's just put it simply that way, right? So they're not necessarily in the trenches and seeing the impact of what they're not doing, right? So if you're not seeing what you're not doing, how are you ever going to recognize, right? So like if I'm in a clinic and I see firsthand when patients get off of opioids, goes on cannabis, and their health improve dramatically. I mean, I'm talking about cutting ER visits, cutting costs. We did some estimates. I mean, people would there was a study done by one of my mentors, Chinaza Cunningham, back in I think 2012. So it's 12-year-old study. 40% reduction in mortality from patients from in the states that approved cannabis from opioid overdoses. 40% mortality reduction. There is nothing come close. Nothing, right? So if you implement uniform Narcan prescriptions, that's like 20-25% reduction. So and have you heard this on a political level discussed? No. Same issue. It's too hard to swallow. They would consider that research. They'll just throw it out and they say that's not important. They'll find somebody critiquing this. That's the problem with research, right? For one study going one way, you're going to find a study going the other way. And then if you're not in a clinical realm of dealing with something, if you're a politician, you don't know which study you should be using, right? You can't synthesize information the way clinicians can. And clinicians have been mostly silent on the topic. And actually, the reason for that has nothing to do, well, it has to do with the federal statute, but it's actually more important. We don't teach our physicians about this topic at all. I'm trying to change that. I'm with Dr. Leslie Mendoza Temple, researchers Ray Lovitz and Yuval Zolotov. We're actually just publishing a study that basically saying, look, every student graduating from medical school must know some core basic information about cannabis. And if they don't, it's basically a problem of the school. And we're going to try to go to Association of Americologists, give it to them and say, look, you have to implement this as a mandate so that every medical student in this country, starting with medical schools, and maybe hopefully at some future point, it'll be every healthcare provider, will have some basic knowledge. But, I think we're probably decades away from that, unfortunately.
I understand that very well. I'm a Marine Corps veteran, and the common theme in any kind of government position is hurry up and wait, especially in the military.
That's right.
Hurry up and get there and then wait, and then that tends to be, unfortunately, the case with, governmental entities, but hopefully we can push the needle on this and continue pushing forward with what we know is helping people. I want to kind of go back to, talking a little bit about, comparing cannabis to pharmaceuticals, right? Because there's a lot of people that come in here and, they might be a little hesitant at first because you're right. There's this old stigma, I call it the reefer madness era, right? Where, people kind of really saw cannabis as the devil's lettuce. And we know that to be very, very different. But many on the other side of that would argue that marijuana as a natural alternative provides a much safer alternative to pharmaceuticals. Can you kind of specifically outline, what distinguishes cannabis from synthetic, medications in terms of efficacy and safety and even patient outcomes? Because you talked about patient outcomes, but just efficacy and safety.
Yeah, it's a huge topic, very important topic. I think one simple way to look at this is, when we're taking medications, we generally tweaking or tricking or modifying our endogenous biochemical pathways. And usually that change is pretty harsh for the system. What I mean by that, generally it goes either against the particular biochemical pathway or it accelerates a particular pathway, but it's generally not self-regulating. What I mean by that, let's say you're in pain, for example, right? So you could say the following. You could say, look, I'm going to try to find out what the pain is from. Let's say that I am athlete and I'm overusing, okay, I'm training for this crazy ski race, 50K race. So I overuse my legs and my shoulders and my arms. So I would take some CBD, CBDA mix on a routine basis, almost daily pre and post workout, because it significantly helps my muscles to recover, and it also decreases my joint inflammation. So now think of this, if I'm going to do this with Motrin, right? So I may reach the same rough effect on the joints, but at what cost? Right? So it's going to upset my stomach. It's going to cause shift in microbiome. It's going to cause increase in leaky gut. So it will cause leaky gut, which is the basically penetration of some of the molecules from the gut into the blood, because that's what Motrin, one of the key side effects of Motrin is causing microbleeding in the stomach. You do this with cannabinoids, and it's such a close mimicking of what our system does anyway, that we don't see those side effects. Of course, you can abuse any substance. I'm not talking about that. I'm talking about taking correct physiologic doses that are not causing serious side effects and are in the consistency of how our body would manage something internally. So let me give you another example. The PTSD is a great example, right? Because we don't really have any treatments for PTSD. The typical prescription for PTSD would be a pain pill, an anxiety pill, a sleeping pill, and then maybe like a beta blocker to kind of calm down the nervous system that is hyper-rated. Why would you do all of those 4 drugs if you can just take one cannabis and it'll hit everything I just mentioned? So, that's another huge point in cannabis. It's the only substance that can pretty much fit into a broad umbrella of medical problems. And it's not the only PTSD, right? A lot of the problems towards the end of life, when people are on hospice, in palliative care, again, same thing. When people enroll in hospice, they get this hospice box that has 5, 6, 7 medications. Cannabis will hit everything too. So, it seems like as we unravel our own cannabis system, which we call an endocannabinoid system, we're beginning to see how we can work with this on a much more physiologic friendly format. And you should ask kind of a critical question, but what about opioids, right? Didn't we try that with opioids and see how miserably we failed? Yes. But there's a big difference. The endocannabinoid system is not present in the brainstem. It's not present in certain parts of brain, and that causes traumatic safety. Unfortunately, opioids very heavily present in brainstem, so the it's very easy to overdose in this. And with cannabis, we're just not seeing this. There's this uniqueness about cannabinoids. Nobody knows what the lethal dose is. There hasn't been any single death reported, and I'm open to say that in public. We don't think there's a single death reported from use of cannabis. If you get too high and you run off the cliff, that's not what I'm talking about. I'm talking about direct causality of cannabis killing someone. That's never been reported. There's no data on that because we don't know what that dose would be. It's impractical to take so much.
And I love what you said about, because there's so many people that will talk about, well, what about the addiction rate? What about the addiction? Well, first of all, anything can be abused. Like you said, we talked about this yesterday. I mean, look at, the obesity rate in the United States is astronomical. Sugar is abused far too much, and it's in far too many of our foods. Not to mention alcohol and maybe other substances, but even caffeine. Caffeine can be highly addictive as well. And that does have a lethal dose. From my understanding, it does.
Of course. No, every year a few hundred people in America die from caffeine. Every year about 1,000 people die from Tylenol, and tens of thousands people die from Motrin every year. And there's not a single death from cannabis in the entire human history. Forget the year. So there's this one of my favorite, when I give talks in medical centers and grand rounds and things like this, I have this table of the toxicity versus efficacy. And it's fascinating. There's nothing come close to cannabis in terms of this ratio of efficacy and safety. You look at, there's some substances that, like for pain, for example, right? So if you have a neuropathic pain, it's this really bad pain where it's a burning like, or sometimes it's called numbing pain. And there's no treatments. The opioids don't work. They're not even listed as a something you should be given. The common medications for that is gabapentin or gabapentinoids, things like Lyrica, Neurontin, those medications. But you look at their efficacy versus safety profile, and there's massive difference. So, because of that, in Europe, cannabis is now first line for neuropathic pain, and gabapentinoids is second, because they did this overall assessment and they realized, wait a second, it's not just about efficacy. You have to include safety in the profile of your treatments. In US, we don't really think that way. We kind of, a lot of the way we practice, I think, is based on outdated guidelines that using often some research from 20, 30 years ago. And when the new research comes up, it's very slow to shift. Of course, it helps that in Europe they do have more pharmaceutical preparations of cannabis, things like Sativex, for example, which is an actual drug. So they do have a bit more of a lobbying that gets through to their governments a little differently. So there are some specific difference in Europe versus US. I'm not a big fan of this whole world of cannabinoid pharmaceutical, not necessarily because I think they shouldn't exist. No, actually, I think they should exist. I just, I've done this enough to see that patients, if you give them a choice and the cost is the same, they would always prefer the plant. It's always more effective. It's always less side effects prone. It's always easier to take, and you have a control over the dosing. That's one thing. Like, when does last time you look at the medication cabinet and you could say, I think today I'm going to take a little bit of this from this jar and a little bit of that, and that's going to work for me. There's no such thing, right? Medications, they prescribe with a certain dosing pattern, and people have very little empowerment. They basically just do what the doctor tells you. Here with cannabis, so many variations, basically unlimited amount of different variabilities between products, between the ratios of active ingredients of cannabinoids, between different terpenes, flavonoids. Each product has its own flavor, its own uniqueness, its own efficacy, its own side effect profile, all of these things taking into account, and you have a system that basically infinitely complex and infinitely leads to chances of success. So if the patient's persistent, my experience, probably more than 90% of patients, when they come to me and they start using cannabinoids for evidence problems, that they will find the right approach.